Thank you so much for joining us. This is our annual DFHCC Data Science event. My name is Franziska Micha. I am the leader of the Data Science program here at the Dana-Farber Harvard Cancer Center. And I'm so excited that David Liu joined me today in putting together our lunchtime event. We decided to focus on prediction of melanoma immunotherapy response this time around because we're all working in this field and we're all interested in doing this. And so before we get started, a big shout out to Erica Feig, who is the program director extraordinaire. And really, Erica, without you, we could never put on any of these things because there's so many, open ends and loose ends, and you always do this so wonderfully. So thank you very much. We have an exciting list of speakers lined up. We have 6 speakers today. Plenty of time for discussion and interaction. We also have a break in between after the first 3 speakers, which is really designed for people to discuss and collaborate. So that's how we're going to do it. Our first speaker is my co-organizer, David Liu. He received his MD and MPH at Johns Hopkins University and then completed his residency and fellowship here at the Dana-Farber Cancer Institute. He's a medical oncologist and computational biologist here and at Brigham and Women's. And his work bridges computer science and cancer biology, focusing on developing machine learning methods to understand and predict therapeutic resistance in cancer. Thank you, David.
Okay, good afternoon, everyone. Thank you, Francesca, for the invite to help co-organize this workshop. Is actually very exciting to have all these people in the room talking about this. So my name is David Liu. Thank you for the very kind introduction. So I'm here at the Dana-Farber, at the Broad, and with affiliations at Brigham as well, medical oncologist and run a computational biology lab here. So today, I think my goal is actually twofold. I wanted to give a little bit of context around the use of immune checkpoint blockade within melanoma, because I think there's a range of different settings that is actually important to think about when we try to think about predicting response to immune checkpoint blockade. So I'm going to start with that, and then I'm going to run through a number of stories that I think illustrate different aspects of kind of this problem, and then and go for there. Hopefully that'll help set the stage for some of the other discussions that happened today. Please feel free, ask questions, or we'll have ask questions at the end, whatever you guys feel comfortable with, but intended to be a discussion. So thank you. All right, this is an overview, clinical context of immune checkpoint blockade and melanoma. So in terms of the different stages of melanoma, so as you know, cancer, solid tumors, stage 1 through 4. Briefly, stage 1 and 2 is when the cancer, the melanoma, is exactly where it has started. So it's still in the primary site and has not gone anywhere else in the body. Stage 3 is when it is actually metastasized or moved away from the primary site and gone to as far as the local regional lymph nodes, okay? And stage 4 is when the melanoma has now traversed and metastasized past that point into distant sites. So the brain, the lung, the liver, as exemplified here, but many other locations as well. And so this is how we stage. Is prognostic as well as dictates what kind of therapies are available in this setting. So the primary therapy for stage 1 and 2 and stage 3 is actually a local therapy. So primarily surgery to basically remove all detectable cancer, right? And then whereas in the stage 4 setting, the primary therapy is actually systemic therapy. So the assumption is if it has metastasized, all the disease that you can see is not the only disease that there is. And therefore, systemic therapy, which treats everywhere in the body, is the primary modality of therapy here. And that is immune checkpoint blockade as well as targeted therapy. So the additional treatments beyond the primary modalities of treatment here is in the early stages, after you remove or treat all the known cancer, is adjuvant therapy, right? Or adjuvant or neoadjuvant therapy. And these are systemic therapies to basically treat the disease that you cannot see. Primarily, this is immune checkpoint blockade, but also target therapy is used in a stage 3 setting that I won't emphasize here. So the key clinical questions with respect to immune checkpoint blockade is different in these different settings, right? So in the stage 4 setting, we now have multiple IO treatment regimens. And so these treatment regimens have different efficacy and different toxicity. And so the question is, for individual patients, is there a way that we can determine which treatment regimens are actually optimal for that patient? So the things we're interested in are biomarkers of treatment efficacy, biomarkers of treatment toxicity, and also the question of how do you make decisions based on balancing these expected efficacy versus toxicity in individual patients. Stage 3 and 2, and in fact 1 as well, a subset of patients are cured by surgery alone. In other words, even if you did nothing, their disease would not recur or cause problems for them. Therefore, any additional therapy in this particular setting lends unnecessary toxicity, which is both financial and health-wise toxicity from the treatment itself. And therefore, in the setting, both predictive markers, which are response to therapy, right, or toxicity, as well as prognostic markers, in other words, how aggressive is this tumor, the likelihood of recurrence, are actually quite informative in the setting to help us decide what treatments are necessary, what kind of management we should do for our patients. And so as an example here is that maybe we want to reserve toxic adjuvant therapy given to patients who are the most likely to progress in a risk stratified fashion and will more likely benefit from treatment. And I think you'll hear some talks around that from this one as well. Please.
Then I can ask you,
please.
So is it if like give it competency IO early on?
Yes.
But then maybe not needed or very much for again.
Yes.
Is there a downside in doing the early check-in?
Yes.
Because I might not be able to use it again later. And what's the
Yeah. So there are multiple downsides here. So one is that when you treat someone with a treatment that is not going to benefit them, one is that it's super expensive, right? So there's a financial aspect of this. Two is that toxicities, including permanent toxicities like type 1 diabetes, right, can be permanent and life altering, right, in these patients. And then the third one, which you actually mentioned here, is we don't know. We don't know whether there's any effect in terms of early treatment, how that affects your likelihood of. Well, we do have some idea, but in terms of that, there is an opportunity cost in terms of the efficacy of the usage of it further down the line. There's a more progressed disease.
Ready to better have one IO, or would it prevent them from getting IO again later, or does it not matter because they already have diabetes anyways, therefore I can try again? So
clinically, especially for these endocrine toxicities where they now no longer have produced thyroid hormone or they don't or diabetes, they then clinically we're like, if we think that this will be important for you from a treatment standpoint for treating your disease, we'll continue to treat you. That's different than other toxicities, for instance, like pneumonitis, inflammation of the lungs, or colitis, or things like that, where you have significant toxicity, may be quite deleterious to you with continued treatment, right? And we would take that consideration into whether or not we would restart you on therapy. Make sense? Great. Thank you. Okay, so that's just the clinical context. And then I'll jump to a bunch of stories here. So I know I'm supposed to see 15 minutes, and I have too many stories here, so I'm just going to run very quickly here. I'm going to give you a little bit more detail in this. So my particular area is advanced melanoma, so mostly in the stage 4 and unresectable stage 3s, where the primary modality of therapy is systemic therapy, right? And so what I'm saying here is that there's now a spectrum of first-line immune checkpoint blockade regimens for advanced melanoma. And so there is a range of different response rates from single-agent anti-PD-1, which is 30–40% response rates, and a grade 3+ toxicity of about 10% or so, all the way down to a combination of anti-PD-1, anti-CTLA-4 at a particular regimen. This is the standard dose, which has a 50+% response rate, but a almost 50% grade 3+ or severe toxicity rate, okay? So increased response, increased toxicity. When you look at this, and this is the updated 10-year follow-up for a randomized control trial of different regimens, what you can see is that the yellow curve or the orange curve in the top is a combination anti-PD-1 CTLA-4, nivolumab, ipilimumab, and the green curve there is a single-agent anti-PD-1, which are the two extremes that I just pointed out to you, right? The 30–40% versus, but 10% toxicity versus 50% toxicity. And if you look at the separation in those curves, you see that there's only a 6–8% absolute difference in survival between anti-PD-1 and the combo therapy, right? But the combo has almost 5 times the severe toxicity rates, right? So one of the questions here is, can we identify which patients are likely to have primary resistance to single-agent anti-PD-1 and would differentially benefit from combination therapy, right? So this is one way to frame this question in a way. And so this was an early study that we did in collaboration when I was in Ellie's group with Dirk Schaddendorf and Bastian Schilling in Germany. where we took a large cohort of patients treated with anti-PD-1, so a single agent anti-PD-1, and did molecular characterization of their tumor. These are pre-treatment tumors, whole exome sequencing, bulk RNA-seq, and deep clinical annotations. And so the first thing that we were interested in asking was, is immune infiltration, so back in 2019, simply, hey, do you have a lot of immune infiltrate? And is that going to predict that you're going to respond to therapy? What we found was that there was not a strong signal for this in the overall setting. But what was surprising to us is that when we actually stratified these patients into their prior treatment history, so there was a subset of these patients that actually had prior treatment with anti-CTLA-4 before an immune checkpoint blockade before they were treated with anti-PD-1. And actually the predictors were very different. Immune infiltrate was actually quite a strong predictor of response in the setting of if you had prior immune checkpoint blockade. But if you're IPI naive, and sorry, I just realized the cursor here. Can you see the cursor? Is this moving? Okay. If you're IPI naive, so you've not had it in the first line setting, there's no difference whether you are immune infiltrated high or low in terms of response to therapy. And so this gave us a model to think about this, which is that if you had if you had a prior treatment with immune checkpoint blockade, but subsequently your tumor was biopsied and you see that there was no immune response in the setting that you had been previously treated, then this predicts that you're going to have intrinsic resistance to subsequent anti-PD-1 therapy. Okay. But in every other case, right, that there is a mix of both responses and lack of response to anti-PD-1. So specifically in this setting. So then we went on with all this data to basically try to build these integrative model across these different types of data. And because of the data that showed that there was a difference in terms of the prior treated versus the IPI naive setting, we built different predictive models. We wanted to build actually parsimonious predictive models because of the problem of overfitting, and we can talk about all the challenges related to that. But we did a parsimonious model here, and we came up with basically separate models for the IPI experienced and tumors and not, which were a mix of clinical features, LDH, as well as molecular features, MHC class 2, and the presence of lymph node metastasis. Separate model here. So here in the IPI naive, which is the ongoing relevant setting, right? Because these are patients. So prior IPI is no longer like a standard of care in the first line setting. So this is the most clinically relevant section, is that a genomic feature, which is genomic heterogeneity, which we can talk more about exactly what that means, genomic ploidy and overall tumor purity were the three features that came through and were stratified patients into those who had who are going to have intrinsic resistance to anti-PD-1 therapy. So the summary here is that there are the prior treatment history is relevant in terms of building these models and what the predictive features. So, and our finding was subsequently reproduced in independent cohorts, like in 2024, for instance. And so we ended up building separate predictive models in these particular settings. And then this three feature model, genomic heterogeneity, ploidy, and purity, predict anti-PD-1 in the IPI naive cohort. And at the time, we only had very limited data that was available, right, in terms of validation of these cohorts. And this is a real challenge. So we didn't have it. But then subsequently, we, in collaboration with pharma and with additional cohorts available here and at our colleagues across town, then this is work led by Giuseppe Tarantino, who is a postdoc in my lab, basically found that these features recapitulated in multiple independent cohorts. So high genomic heterogeneity and low ploidy associated with intrinsic resistance to anti-PD-1 immune checkpoint blockade in 3 independent cohorts. And beyond kind of looking, and by the way, one dropped out, purity dropped out, right? Which is good. I mean, in the setting like, well, it didn't validate, so fine, it didn't validate, which is what the point of the validation cohorts are. So then the question that we wanted to ask was that, can we use this information to actually build a useful predictor, right? And so but the question is, when you build a predictor, what do you optimize for? And in this particular case, we thought that the more useful clinical application was to build something that had high specificity. So high positive predictive value. If you predict that someone's going to have intrinsic resistance, then they're very, very, very likely to have intrinsic resistance. You're very sure, in which case you can take a different action. And in this case, so we built out this very simple two input model, and just found, and there's a particular thresholds that had 90% positive predictive value, right? And you can see that the difference. So you're not predicting as many people who are going to be intrinsic resistant, but you're predicting. But for those who you predict, you are very confident that they are going to be resistant. So this model validates another independent cohort of immune checkpoint blockade treated patients. And then the interesting part of this is then the idea is if you is that you would treat those people predicted to be resistant with the combination therapy, which is higher toxicity. And what we see in the setting with the combo therapy here is that there are, among these people, they're still resistant, which is actually not too surprising, but you do see 3 out of the 7 patients predicted as intrinsically resistant respond to combo therapy. So suggests some idea that this might be useful. So heterogeneity are robust predictors resist across multiple cohorts. Also, we looked at this in combination in comparison to a bunch of other predicted signatures and other predictors in the past, and this seems to be a good predictive model. And that doing this kind of optimized predictive model towards some kind of clinical question can potentially be useful in terms of making a clinical decision towards a combination therapy versus IMD. So moving forward towards clinical translation, we're interested in developing like machine learning models, computer vision models, led by a number of folks. So Mark Ledig was a former ACBM lab who's now doing his PhD at ETH Zurich. Giuseppe Tarantino and Bojan Carlos, who is a computer science postdoc that shared between my lab and Eugene Semenov's lab, who you will hear from in a little bit. But towards using H&E to infer some of these molecular characteristics and use prediction. The other part is towards biology, tumor intrinsic and microenvironmental features, basically that might be associated with some of these features to help us understand what these actually mean, genomic heterogeneity and fluidity. Okay, so I will run again through because I am way over time, I'm sure.
Sorry about that.
So the other part is story I want to tell is circulating predictors of durable response to combination anti-PD-1 anti-CTLA-4 in advanced melanomas. So the question here is that, we're talking about sampling tumor microenvironment, right? And so the other way we could look at this is say, what about something a little bit easier to get to that's reproducible and those things, which is blood. So the question is the response to immune checkpoint blockade predicted by circulating cytokines and or white blood cells? And so in this particular study, this is in collaboration with Steve Hody here at the Dana-Farber, and then a study. So basically, these are patients treated with combination anti-PD-1, anti-CTLA-4. Blood was collected from 3 time points: pre-treatment, post-treatment 1, and post-treatment 2. Post-treatment 1 was about a month or so after initiation of treatment. Post-treatment 2 was about between 3 and 6 months for the treatment. And so the idea is that you collect blood, and then separating out in 2 different components, the white blood cell component and the plasma component. And the plasma, and what I'll talk about today is the plasma component, soluble cytokines were assayed using Luminex. And so the idea here is, and this was work that was led by Jiajia Chen, who is over there, a computational biologist in my lab, and with Giuseppe, and using that to predict downstream outcome. So cohort 89 patients or so, the characteristics of the cohort are consistent with what we expect with immune checkpoint with combination anti-PD-1, anti-CTLA-4. Interestingly, 27% of these patients had prior immune checkpoint blockade as well. Sorry, checkpoint inhibition. You'll hear these various acronyms, but they all mean immune checkpoint blockade. So if we're just looking for which cytokine, so from a predictive standpoint, the most useful thing is the pre-treatment time point, right? Because it isn't like, oh, now that you are 3 months into treatment, I can now tell you that you are responding to you will respond to treatment, right? So the most useful thing is kind of a pre-treatment. That's what I'll focus on here, though there's more here. So there are particular cytokines that seem to be enriched with response to or resistance to immune checkpoint blockade. So in particular here, we had CXCL5, CXCL6, IL-23, and IL-10. And not to go, we also had lab values and other things here, just to say things that were associated with non-durable clinical benefit. But I will pass that for right now. But the important things, and we looked at the associations between CXCL5, CXCL6, and IL-10 and IL-23, and looked at their independence versus correlation. And we put these together into a combined multivariable prediction model showing improved performance as you kind of go forward and increase the number of features here. So the major thing, and from here, what we did was to build a composite score. So basically treat each of these different features, just a median split, high versus low, and treat each one as a score, right? So a composite score based on the number of favorable characteristics, it makes it easier to potentially use. And we show that there's a pretty good stratification between progression-free survival when you look at these scores. So scores 0 through score 4. One thing I wanted to point out here was that prior IO is associated with differential baseline cytokines. I told you that 27% of folks. had different characteristics, had prior immune checkpoint blockade. So you see GCSF for 1BB, McA, McB. And if you separate those out, so it's 27% of the cohort had prior immune checkpoint blockade and 83% or 73% did not, right? So overall, if you look at this 3-feature model, that you actually see reasonable performance in both of these cohorts for the 3-feature model. But when you look at the individual characteristics, you actually see that there are that there are stronger signals actually for in one group versus the other. So pointing out here, for instance, the IL-23 is the strongest signal is high levels of IL-23 is associated with durable clinical benefit in those with naive who are naive. But there's not a signal in those who had IL. So from here, just looked at these circulating cytokines as pretreatment predictors of combination IO response and resistance, and then developed this predictor based on composite scores. And then the limitation, of course, in this particular case, initially we were planning on doing like, hey, 40 as the discovery and, and 50 as the validation set. Didn't quite work out for a number of different reasons because of the characteristics of the cohort. But the issue is, of course, this is one cohort, and you need to validate an independent cohorts here. And the note, prior IO therapy still associated differences based on cytokine levels and predictors of response. So prior therapy is still important. Last one, immune infiltration distinguishes programs of primary resistance. Just very quickly, this is led by Amy Huang, who was a computational biologist in my lab, who has now moved on to her PhD program at MIT. And the question here is, what are the differential predictors mechanisms of response resistance to different immunotherapy regimens? Can we identify mechanisms of resistance and targets to improve efficacy, reduce toxicity? Can we identify which patients are likely to have specific mechanisms of resistance and would benefit from specific combinations? And so this was a meta-analysis of all the available data with really clear clinical annotations given the things that we had learned previously. And pretreatment samples with bulk RNA-seq sequencing. And this is on bioRxiv. So you'll see some things unpublished, but they're on bioRxiv now. So you can take a look at that. So meta-analysis of eight different published and unpublished cohorts of immune checkpoint blockade treated patients with detailed clinical annotations, broken them out into these anti-CTLA-4 treated, anti-PD-1 treated, anti-PD-1 treated with prior IO with anti-CTLA-4 given what was previously known, and the combo therapy. Initial hypothesis was that, different immune environments might be associated with different, responses with different treatments. What we found was that based on some prior papers, like from Bagayev, others that found different microenvironments, what we found was that we just didn't feel like we could distinguish different immune microenvironments very well, like with any confidence. But what we could see pretty clearly was that there were immune high versus immune low microenvironments in tumors. And so the question here is then, if you look at immune high versus immune low, are there differences in terms of response to therapy? Are there differences in terms of predictors of response to therapy between high and immune low? And what was interesting to us was that the immune score that we came up there differentiated response versus non-responders only for combination immune checkpoint blockade and anti-PD-1 with prior CTLA-4 for combination, but not for single agents, anti-PD-1 or anti-CTLA-4. And this was counter prior notions in some sense. This is showing this again, like immune high status conferred this consistently higher odds of response in combo and anti-PD-1 with prior CTLA-4 ICB treatment. This is contrary in the sense that there is the thought that cold tumors are the ones that would benefit from the combination because it will induce a de novo immune response, right? But what we're actually seeing is it's kind of the rich are getting richer in some sense. It's actually, you have very high response rates in those that have evidence of immune infiltrate, as opposed to those that are better response with combination versus the cold ones. And so in the immune high tumors, we're looking for features that are associated with resistance we looked specifically in anti-PD-1, and what we found was that there are a number of signatures that were associated with hypoxia, angiogenesis, EMT associated with resistance to single agent immune checkpoint blockade, specifically in the immune high setting, but not in the immune low setting. This is basically showing the scores. So if you look at these homework signatures, that there are differences between those who have responders versus non-responders, specifically in the immune high setting, but not in the immune low cohorts. And then there's biology, of course, associated with hypoxia that I'm not going to go into here. I will skip through this. We then did some characterization of single cell cohorts and correlations with scores of hypoxia to understand what are the cells and the programs that are associated with higher levels of hypoxia within a tumor microenvironment, and basically identified a particular feature, which is HIF2 alpha, that was found particularly in stromal cells, stromal and myeloid cells, and actually found that as a potential target actually for modification. And again, I apologize. I'm just going to run through here because I think maybe less relevant for this population. And then did some functional studies that then looked at the treatment. So the hypothesis is that modulation of hypoxia is particularly relevant in an immune high setting. Okay, modulation or treatment of hypoxia is in an immune high setting. So looked at this in different in vivo murine models. This is with Arlene Sharp and Kelly Burke, and looked at B16 OVA and B16 as kind of immune high versus immune low setting, and treated with a HIF2 alpha inhibitor, PT2399, and combination and with and without anti-PD-1 immune checkpoint blockade. What you see is basically that you see this tumor growth curve is a combination of blocking HIF2 alpha and anti-PD-1. So there is a combined effect of the two versus but only in the immune high setting and not in the immune cold setting. So kind of consistent with our hypothesis. So all that to say, patient population is heterogeneous. And that's one of the hard parts in terms of predictions, right? Because of the heterogeneity in patients. In this particular case, what we hope we've shown is that a careful stratified analysis by the immune infiltrate clarifies which patients will have differential responses by treatment, as well as the context-specific predictors and mechanisms of immune checkpoint blockade resistance. Yeah, so this is just how this maybe makes sense in the biological setting. This is the tumor immunity pathway, this is the idea of a good tumor immune response, if that makes sense, starting from the tumor and induction of immune response within the lymph nodes, then trafficking of T cells down into the tumor. And the idea is that an immune high tumor has successfully gone through the tumor immunity cycle up to a certain point where you have immune high, where the barriers in this particular case may be more hypoxia related. And that is different than a cold tumor where there is a failure somewhere earlier in the cycle, and therefore the mechanisms and the potential targets are going to be different, right? So that's the basic idea. And there's subsequent downstream stuff that we're. So the last thing I just want to say is just that clinical context matters, okay? Prior therapies, differences in immune checkpoint blockade regimens. The stratification by these biological relevant parameters can clarify these subpopulation-specific predictive features and models. And we've identified a number of these different features, but it also immediately raises questions. Can integration of these different modalities improve prediction? But it also immediately highlights the lack of and need for multimodally profiled patient cohorts with these deep clinical annotations in order for us to ask this question. And the other direction is reusing these common clinical assays like the H&E and the computer vision, to which you'll hear about in, I think, in a number of talks, to infer these predictors is a promising new direction. So lots of people to thank. I tried to highlight them along the way. Quite a few folks who are presenting here today, my lab members, but funders, and most of all the patients who enable us to be able to do these studies. And thank you for your attention. Carol, please.
Any questions?
Yes, thank you for the great talk. Yeah. You started saying, oh, there are costs, there are toxicities.
Yeah.
That's why it's important. So is your impression as of today that you have to predict toxicities together with efficacy for good clinical decision making, or
so what
doesn't matter much?
Well, what I will say is that clinically we do this already, right? In some sense, where like what we say is that, hey, in this 80-some-year-old gentleman who has a history of COPD and is on oxygen, right? We're like, I don't really want to give this person combination immune checkpoint blockade, right? Because it is sort of a prediction of toxicity. It's also a prediction of how bad what is the ability of the patient to tolerate the toxicity, right? So we are doing this already, and patients with autoimmune disease and concern that we treat them with immune checkpoint blockade, that they're going to exacerbate their.
Doing with formal models,
no,
or just
no, not formal models. Just and Riz is smiling over there, and Eugene, and so we're no, not at all formal, but just based on our clinical judgment, basically our own visual experiences and talking about.
Thank you. How does the anti-P1 and CTLA4 toxicity present in the clinic? What does that look like?
So, by the way, just to answer like you also hear some actual formal prediction of the toxicity. Sorry, and so how does it present in clinic?
Yeah.
So it can either present as someone calling us saying that I'm having trouble breathing and coughing, right? So pneumonitis, I'm having diarrhea, like 6 to 10 episodes of diarrhea a day. They can show up in clinic and they have yellow eyes, yellow skin, and that's a manifestation of hepatitis, right? Bilirubin. There are many different ways of that. It's either because it's symptomatic or
And the second question for the hypoxic environment
Yeah.
for the anti-PD-1.
Yeah.
What do you suspect is going on there? Is there a change of pH that's helping the immune system?
Yeah. So hypoxia has been has been studied a lot, right? And so there's very, very good, of course, data that hypoxia results in kind of suppression. So there's a whole both in terms of pushing particular cells like myeloid cells towards a more immunosuppressive phenotype. There's decreased function of particular T cells away from effector type population, more exhausted type population. Like there are a bunch of different mechanisms that are associated with hypoxia. In terms of how it works to target the hypoxia, I think one thing didn't show it here, but there are some clinical trials of angiogenesis targeting the anti-PD-1 that seem to show actually optimization of the hypoxia seems to be associated with better response.
So thank you.
Just some phenotype, not mechanism, but
Yeah, thank you.
Just maybe a quick question. For the very first example where you have intrinsic resistance to anti-PD-1 monotherapy, but
Yeah.
that those patients are still responding
Yeah.
to the combination therapy. Do you have a sense of like mechanistically what's happening there? Is there some synergy between the combination treatments, or is it just like if you had a delta dose of anti-PD-1, would you also overcome the resistance? Or
So first of all, I think it's already an assumption, and I think it is an assumption by the field, which I'm not sure is entirely important, that if you're going to respond to one therapy, you have it. Right. So probably, but just to say that is an assumption. So why is it that they do respond? So first of all, I would say that they're different, they're different mechanisms. So they're different checkpoints that have expressed and have functions in different immune cell types, right? So probably the combination of the two is what is happening in terms of the double dose of anti-PD-1. So I think that the preclinical studies and other studies that we have is that the amount of PD-1 that is given is actually fairly saturated in some sense. So it isn't that you give twice the dose or something like that, you're going to get a larger effect. That's actually PD-1 is slightly different. Like for CTLA-4 blockade, there's actually significant differences in toxicity if you give like 1 milligram like that. But there's probably some kind of synergistic effect. The truth is, I don't know if other people feel differently. There's expertise in this room, but I think how the combination of antibiotics for humans is not super. It's not super broke down. In a mouse, there are some things like it depletes Tregs, but that's a particular feature of how they study. But I love that too.
You speculate a little bit further hypoxia. I guess one act, I think. What does it teach us about which one?
They have two of them.
You have to have them. Okay. What does it teach us about immunotherapy response prediction for other cancer types?
It's a good question. Well, so it's interesting, right? So renal cell carcinoma, right, is the one with angiogenesis and hypoxia, but it's also RCC. So I'm not an RCC biologist at all, so there are probably people with much more knowledge about this. But so in that particular setting, it's where mutations in the activating mutation pathway are those that are oncogenic, right? Are the ones that are the dependent. So RCC seems potentially is a different histology, right, and a different set of mechanisms. So taking away RCC, right? Hypoxia is generally is considered to be a general feature of solid tumors in general. But I think what we're showing here is that there are different, even within solid tumors where hypoxia is a general feature, there are different levels of hypoxia that we're seeing variability between patients where that that is predictive of a potential target and response to some combination therapy. And I lost the thread about speculation.
The question was whether this is predictive of other cancers, right, for IO response.
It's a good question. I don't know.
I guess we'd have to show it.
Yeah, exactly. No, I would be curious if that's exactly what. And actually, not to whatever. Like our feature of being high versus low was based on RNA-seq. Very just you saw the hierarchical clustering and it was just being high versus being low. But in terms of actually doing that, you don't have to do both RNA for high and low. You can do like H&E imaging. We did some of this actually, and we can quite easily actually. So you can get it even without it.
All right, any final questions? Oh, here. Yes.
Good.
Oh, sorry.
The model that you presented, I think near the beginning, the model that in the beginning that was genomic heterogeneity equality, was that based on whole exome sequencing?
It was based on whole exome.
And is that, I guess, are you thinking that, is that just an extension of the idea that you have more, which I didn't know which way the genomic heterogeneity was going, but more heterogeneity is more indicative of immune targets?
So it's different than tumor mutational burden.
Right.
Sorry, I didn't get into this. Take much time. But TMB, right, is tumor mutation burden. The idea of the hypothesis, the higher tumor mutational burden, these are potential neoantigens, right? So basically novel peptides for the immune system to respond to. Higher your TMB is, the more likely you are to respond to things like that. Now, truth is, it's a very poor biomarker, right? It just doesn't work all that well. And RCC, for example, doesn't have a very high tumor mutation burden, yet it responds very well. But genomic heterogeneity in this feature is actually defined by the proportion of subclonal mutations. So what this means is that when we call mutations, we also call what proportion of tumor cells have it. So a clonal mutation is a mutation that's present in all tumor cells, right? And so presumably it's some part of some parental clone for the cancer. But then the proportion of subclonal mutations are mutations that are referred to be in less than all of them. So representing some kind of subclonality heterogeneity. And so that's what we are finding is associated with not the tumor mutation burden itself, but actually the
in this case, the having more subclones is a negative indicator for response.
Yes, actually higher heterogeneity, more subclonality associated. And there's a lot of interesting things with that we can talk about because it seems an intrinsic feature of the tumor itself and less associated with the actual treatments and other things that we can talk about. But
I am calling it a
Please,
day.
sorry.
Otherwise-
Nobody has time.
That's
All right,
all.
thank you.
But thank you very much, David. Next